So thank you. It is a pleasure to be speaking in this Indo-Russian Ophthalmology Summit on the 93rd birthday of Professor Fedorov. And I would be talking to you about IOCT guided anterior segment surgeries. And I would like to acknowledge at the outset that Dr. Malugan has done a lot of work and has many award-winning videos on intraoperative OCT in relation to cataract. So, coming to the cataract surgery first, it is a great tool to have in the cataract surgery itself because when you make the incision, you know at what level the side ports are being made and at what level the main port is being made, whether it is uniplanar or whether it is biplanar. So the architecture, the wound architecture gets better. Then also when you make a capsulorhexis flap, you can actually see the flap being lifted onto the lens. And this is of special benefit, especially when you have hazy corneas and you can't make out where the edge of the flap is. You can actually relocate the flap by moving the eye a little bit onto one or the other side. And the capsulorhexis can be very well delineated. Then again, when you do hydro procedures, you can actually see the hydro waves inside the nucleus which are generated as the nucleus and the cortical matter is disassembled. And as the nucleus is moved again, the cleavage of the cortical fibers and the nucleus can be seen. Then as you make a crater there, you can actually see the depth of the crater and also the underlying plate which is left as you sculpt. And as you chop, one can again see the chopped areas very well. Then this is the cortical plate which remains, and the cortical plate is snugly fitting the capsular bag, which again can be highlighted. And when you remove the entire cortex, there'll be a bulge which is present, and then you can see that there's a PC which is intact, and then you can put the intraocular lens inside. IOL insertion can be done after putting viscoelastic so that the bulging PC it moves at the back. And then just prior to the aspiration of the viscoelastic, one can see that there is a gap which is present between the IOL and the PC. And as this viscoelastic is aspirated, this gap would decrease. And depending upon the fit of the bag, sometimes this capsule gets crinkly because if there's a mismatch between the lens size and the capsular bag, and sometimes it is taut depending upon the depending upon the size of the bag as well as the lens both. And as you hydrate, you can again see that the wound will get closed more on the internal side, not on the external side here. So you can adequately titrate your hydration as well so that a spindle would form. If there's a small desmosed membrane detachment which is present in the wound side, even that can be highlighted and that can be addressed by putting an air bubble there. And subsequently the port side DMD also can be managed likewise. Now in different situations, for instance, this is posterior subcapsular cataract, so you can see that there's an intact PC which is present here, and this would be different if you have a posterior subcapsular cataract. And if there's a gap there, you can make out this is a posterior subcapsular cataract, although there's not a gap here. And in white cataract, you can see that the cortical fibers as well as the fluid clefts. And when the fluid clefts are present, you know that there is these dark areas reflect the fluid areas which are present here. And one can then do a capsulorhexis looking at this. And subsequently, when it's a complete white cataract, so that only the fluid comes out, then you will not be able to see anything beneath the fluid that comes out, which happens in some of the cases also. So in this, the capsulorhexis is being completed, and you can actually see the capsular flap there. And this is a case in which you can't see anything beneath because it's a completely liquefied cortex which is there. So as soon as you give a nick, you can see nothing but the uh, blob of the fluid which comes out. And even in capsular distension syndrome, it is helpful. Notice the gap between the lens and the capsule. And now, after you've removed that tight rim all around, it is just abutting, the lens is abutting against the capsule. And the myopia of the patient is relieved once you do this. because the fluid which is present between the capsule and the lens has been removed. Now, it is a great tool in cases of Descemet's membrane detachment. For instance, in this case, when there's a DMD there, you can actually see and you can actually inject the air bubble or SF6 gas. Now, if you didn't have the IOCT, you would probably think you're done, but you're not, actually not done, because there's still some amount of fluid which is present there. And for that, you have to actually put this bubble for good 5 to 7 minutes. And when the needle comes out again, you can see that there's a shallow detachment which is there. So as the needle comes out, put some slight amount of pressure there so that the air bubble doesn't egress out. And only when it is completely attached, the cornea also gets a little bit clearer on the table, then you know that your Descemet's membrane is quite attached. Now, this is just to show that this helps you on the table. This was a case referred for corneal transplantation, but by just doing a gas fill, we were able to defer corneal transplantation procedure. Then very useful for big bubble DALCs, such as in this case. So a big bubble is being made using air after doing trepanation 50 to 60%. And once you do that, the Descemet's membrane falls back. This is an inverted image. This has to be re-inverted. And after you give a nick on the overlying stromal layers, just look at the way in a live show the Descemet's membrane is marching towards the overlying stromal layers as this air bubble is coming out. So you know that you're still extraocular. You've not penetrated the Descemet's membrane or perforated it. And after this is then reinforced with the help of viscoelastics. So like a kangaroo's pouch, it moves at the back, and then the overlying stromal layers are then removed, which are diseased. And this is the bare Descemet's membrane, which is actually looking at you, which is so beautifully seen on the Intraoperative OCT microscope. And then one can then suture the graft in place. And this is how, visual acuity 69612 after grafts, and the procedure is still extraocular and not intraocular. Even when there's a opacity which is present because of healed hydrops, then also you can actually see on the intraopposite microscope and titrate your surgery. So this is the trepanation which is being done, and layer by layer dissection. And just as you come underneath that area over which a little bit of haze is there, one can just titrate it looking at the IOCT and go a little more superficial in that area, so that although you have a little bit of haze but not complete haze, especially in the center, and this can be very well delineated with the IOCT. This is in the post-op picture, and this is 52 microns, which is hardly any stroma. Then when you're doing surface procedures like slit, again, it helps you to delineate the overlying pannus with the underneath cornea. And when you remove the pannus, the underneath cornea is quite clear. And these are little pieces of limbus, which are then placed in a slit procedure so as to cause epithelialization. And again, you have deferred a corneal transplantation procedure in this. And IOCT helps because you know where the cornea is and where the pannus is. So again, this is just to show the same procedure after doing a slit. No keratoplasty which required, and patient was 6'6" in the post-op period. Then again, in cases of desmetoceles, for instance, such as this large desmetocele, a bit piece of tissue is taken, and then this is being glued to the edges. And again, you can see on the IOCT, you can see that there's some gap there. So you know that you have to nudge it a little bit more so that it gets stuck to the edges. And when it does get stuck to the edges, you know that there's no gap there, and then you know that you are completely done and you can leave it like this. So this is in the post-op period. Then again, if you have a Descemet's membrane detachment in such hazy corneas, you really don't know where you are injecting the gas. So if you have an intraop OCT microscope post-DALC Descemet's membrane, you can actually make out. And after putting air bubble also, you can see that it's not getting stuck. So anterior stromal punctures are done, and then air bubble is instilled again, and then you know it is quite stuck, and you know that the Descemet's membrane is pretty much attached. Now this, I'm sure, will be shown in the subsequent presentation, but this is a DSEC case. So when you're doing DSEC in hazy corneas, you can actually make out where your graft is. So once you put the air bubble, the graft gets stuck to the back of the cornea, and in real time, it's like a third eye. It actually shows you, you know, what you're doing without having to imagine it. So you know that the graft is quite stuck. When you have very thin, ultra thin DSEC and your graft goes inverted, like in this case, this is an inverted graft. So you don't know what to do about it. But if you have an IOCT microscope, you can make out that now it is in the correct orientation after flipping it, and then the air bubble can then be instilled, and the graft is stuck pretty much to the back of the cornea. And this is just to show how a DMEC is done. So Descemet's membrane, all the diseased Descemet's membrane is removed. Seeing on the IOCT or intraop OCT, this is the Descemet's membrane scroll which is taken, and this is then placed inside the anterior chamber. And then you have to look at this configuration, biceps curl upwards. So now this is absolutely inverted. So this has to be flipped. And even if you have not put a S-shaped stamp on it, you can just see that once you get that biceps curl, and then it gets stuck to the back of the whole graft is stuck to the back of the cornea. And this is post-operative week 1, and this is at month 1. You can't even make out that there was ever a graft there. And this is something that we innovated when we had a lenticule piece which was stuck in the interface. So we tried to remove it with the help of the IOCT, because we could delineate on the very same day on the table where it is, because we had intraop OCT microscope. So one can delineate the edges of the lenticule which is sticking inside the interface, and so that can be removed, and one can then check the interface to see whether there are any remaining lenticule bits which are present or not. So intraop OCT microscope is a great tool to have. It is like a third eye. It helps you to see things which earlier you had to imagine, and it gives you a third dimension into the whole dynamics of your intraoperative surgery. And it is here to stay, and I'm sure it will refine further and become better. So thank